Hello, this is Andrea Wolf, and this begins our discussion of drugs affecting the endocrine system, starting with anti-diabetic drugs. So when we look at diabetes pathophysiology, we have four primary alterations in glucose metabolism. First, insufficient production of endogenous insulin and amylin by the beta cells in the pancreas, and of course this is what we see in type 1 diabetes. Secondly, tissue insensitivity to insulin, which we see in diabetes type 2, an impaired response of the beta cells to blood glucose levels, and excessive production of glucose by the liver are secondary to increased glucagon levels. So the main physiologic alteration in type 2 diabetes is insulin resistance, meaning that there's a suboptimal response of insulin-sensitive tissues, especially the liver, the muscle, and adipose tissue, to insulin. So type 1 diabetes pathophysiology involves autoimmune destruction of the beta cells in the islets of Langerhans, which means that there's an absolute need for exogenous insulin because there's no endogenous insulin produced. In type 2 diabetes, the pancreas produces insulin initially, but that declines as the disease advances. So it could almost be said that by the time diabetes is diagnosed, you've lost about 50% of the beta cells in the pancreas. So that process goes on over a long period of time. So eventually there's beta cell, the beta cell responsiveness to glucose level declines, and the liver and incretin hormone system, which we'll talk about a bit later, are the major targets for treatment. And then, as I said in the previous slide, adipose, liver, and muscle tissue becomes resistant to insulin. So we have multiple issues going on. We'll start by talking about insulin. So what is going on with insulin? Well, we know it's released from the beta cells, and that generally tends to be a constant rate, but there may be intermittent bursts when there are reasons where the body needs higher glucose levels, such as in time of stress. We often see that in the hospital when patients undergo surgery, for example. We see higher needs for insulin, and sometimes patients need to be started on insulin. We know that it allows more glucose to enter the cells because it binds with insulin receptor sites on cell membranes. It acts in the liver to increase storage of glucose as glycogen, and in the tissues, such as muscle cells, it promotes protein synthesis. It also plays a role in triglyceride storage in the adipose tissue. So insulin is a small protein molecule that's secreted by the beta cells of the pancreas, and it's essential to the utilization of glucose by all cells in the body. The actions of insulin are on the glucose transporters that cause the uptake of insulin in various tissues. It acts on the liver to increase storage, as I mentioned. It acts on muscle cells to promote protein synthesis and glycogen synthesis during exercise. And it acts on adipose tissues to reduce the circulation of free fatty acids by promoting the storage of triglycerides in the adipose tissue. And of course, this is a major problem for patients who have higher and higher incidence of insulin resistance when there is increased adipose tissue. So when we give insulin, we have to keep in mind that people gain weight, which can be counterproductive to treating their underlying problem. So this gives an overview of the types of insulin and what their onset, peaks, and durations are. So we have rapid-acting, or Lispro, Humalog, or Aspart, Novolog. Also, Apidra is something I don't see very used as often. It's probably one of the newer ones. Short-acting or regular, which we don't use very much. Intermediate, or NPH, which we also don't use very much, unless people are using combination insulins. And then we have long-acting or basal insulin, which tends to be the standard of care. One that's considered ultra-long-acting basal insulin is called Tresiba. And that's something that's been very effective. And then we have fixed combinations, and this is the only time that I've really seen any NPH or regular insulin being used in these combinations, which are not as popular because it tends to be more difficult to determine what's actually going on and how to regulate sugars in these combinations. But they are cheaper, so sometimes we will need to use them. And then there is human inhaled insulin, which I haven't seen, but which may be used in some settings. Afrezza, which is the most rapid acting of any type, with a very quick onset of 12 minutes. So the pharmacokinetics of insulin depend on the type of insulin, where they are injected, and the volume injected. And abdominal injection sites tend to absorb 50% more than other sites. So that's something to keep in mind in patient education. It is excreted in the urine. So this shows some approaches to dosing. We're not going to get too much into that in these slides because that really comes later with diagnosis and management courses. But one approach to initiating insulin is to start with a basal insulin and titrate the dose according to the fasting glucose readings. So you have to have a patient who's motivated to do those. Another approach can be to calculate the daily need for basal insulin and then give 50% in basal insulin and the other 50% in short-acting insulin. You can also start it at a lower dose while adding oral agents, though generally we try to do the oral agents first, monitor the A1C, and then do those on a every 3-month basis. So we may have to wait a little bit when we start oral agents to see what our response is before we would jump right into insulin. So I wouldn't recommend adding insulin and an oral agent that's new at the same time. This shows the adverse drug reactions. Of course, hypoglycemia is the biggest thing, and sometimes we just have patients who are much more sensitive to hypoglycemia and pose a huge problem in trying to find good regulation with insulin. And so those people really belong with an endocrinologist. We do have some concerns about pregnant women. Short-acting or rapid-acting does not cross the placenta, but the basal insulins have not really been well studied. So the only contraindication would be, hypoglycemia, and we don't know that until we try it, and then we just, try regulating. But if we continually have hypoglycemia, we may just need to stop insulin. Keep in mind that patients with hypothyroidism, those patients have a delayed insulin breakdown, so they might require less insulin, and patients with hyperthyroidism may have an increased renal clearance, so they require more insulin than patients who do not. And in patients that have liver and renal impairment, we may see increased circulating levels of insulin. So we need to keep that in mind in terms of cause of hypoglycemia. Monitoring is always done with a glycohemoglobin or hemoglobin A1C. We always have to monitor renal function because many of these drugs that we may be using, including insulin, may have an effect on renal function. And we often test the CBC. A1Cs are generally done on a quarterly basis, but if patients are really stable, we may do them less frequently. Now I'm going to get into the non-insulin anti-diabetic agents. So these are all the different agents that we can consider that are non-insulin agents for diabetes, most of which are used for diabetes type 2. So this slide shows the many actions that various drug categories are useful for, and the organs in which they're useful. And we're going to get into the individual ones in subsequent slides. So these next two slides show the mechanisms of actions of these anti-diabetic agents that are not insulin. And most of them are going to be used for type 2 diabetes. So one of them would be first one being tissue insensitivity to insulin. That's the major problem with type 2 diabetes. And really, it's only the TZDs and metformin, with metformin really being the drug of choice to start with, that are going to improve insulin sensitivity. And that means the ability of the tissues to actually use the insulin to decrease glucose. The next issue of impaired glucagon peptide 1 activity. So for excessive production of the glucose in the liver, metformin and alpha glucosidase inhibitors are going to be helpful. For impaired response of beta cells, meglitinides will be useful. And if there's insufficient production of endogenous insulin, we have the sulfonylureas. So of the biguanides, metformin really is the only one that we have available to us. So this drug class was developed many years ago when sulfonylureas came out on the market, but they were never put on the market due to concerns about lactic acidosis. But later, those concerns were minimized, and metformin came onto the market, and now that's the only one that we have in this class. So initially, the guidelines for creatinine levels were more restrictive regarding lactic acidosis, but those have been more relaxed in recent years, and we can safely use metformin in many patients. So patients that have renal impairment, when given metformin, are going to be more prone to developing lactic acidosis. So it has its action in the liver and in the intestine. And in the liver, it'll decrease glucose production, and in the intestine, it will decrease absorption of glucose. So together, these actions actually address the primary pathophysiologic defects of type 2 diabetes to improve glucose tolerance and to lower both the basal and the postprandial plasma glucose levels. So metformin is usually weight neutral, where patients may actually lose weight. And as I mentioned, they're first line for adults and also can be used for children over 10 years. We also see them used in patients with prediabetes, and patients that have polycystic ovarian syndrome tend to have prediabetes and insulin resistance, and so metformin can be helpful for these patients. And it also has a favorable impact on lipids because of its action in the liver. So these are the pharmacokinetics of metformin. Some things to keep in mind are that the extent of absorption of the extended release metformin formulations is increased by approximately 60% when given with food. It is excreted in the kidneys, and another thing to keep in mind is that alcohol can potentiate the drug's effect on lactate metabolism. So patients should be warned about alcohol use. Some precautions, as you know, we talked enough about lactic acid, but there is a contraindication in patients with a GFR of less than 30. It's recommended to withhold the drug 48 hours before and after procedures involving iodine-based contrast mediums, because we know how that effect has on creatinine. If patients have B12 deficiency, there could be a drop in B12, so that's going to be an issue. And I already mentioned that they are indicated for children younger than 10 years of age. So to reiterate about the contrast agents, in metformin-treated patients, it can lead to an acute decrease in renal function, and so that could predispose to lactic acidosis. In patients with a GFR between 30 and 60, this is going to be particularly important. Also in patients that have a history of hepatic impairment, alcoholism, or heart failure, or patients that will be administered intra-arterial iodinated contrast, we also need to consider stopping the metformin prior to these procedures. We can evaluate the GFR 48 hours after the imaging procedure and then restart it if the renal function is stable. So monitoring, again, while lactic acidosis is rare, we do need to continually monitor renal function at the start, as well as every 6 to 12 months, depending on the patient's status. Contraindicated in GFR is less than 30, and not recommended if under 45. So we need to watch that. When lactic acidosis does occur, it's fatal 50% of the time. And as I mentioned, there's an increased risk if there's hepatic dysfunction as well. So these two contraindications are more serious than either one of them alone. So symptoms to look at, I have listed here: malaise, myalgias, respiratory distress, somnolence, abdominal pain. They may have elevated blood lactate levels. Look for an anion gap acidosis, an increase in the lactate pyruvate ratio. And also look at metformin plasma levels that may be generally greater than 5 micrograms per milliliter. So one of the things I haven't mentioned is that I'm going to try and present these in. So this shows the role of the incretins in glucose homeostasis. It starts with ingestion of food in the GI tract, and so there's a release of the gut hormones, which are called the incretins, and those are GLP-1 and GIP, as I already mentioned. Then take notice of the DPP-4 enzyme, which is we'll also be discussing. This inactivates those incretin hormones, so we use DPP-4 enzyme inhibitors, to promote a decrease in blood sugar. But when those hormones are released, which occurs in the presence of glucose, the GLP-1 and the GIP cause an increase in insulin to be released from the beta cells, and GLP-1 causes a decrease in glucagon to be released from the alpha cells. As a result, there's an increased glucose uptake by the muscles and decreased glucose production in the liver, which results overall in a decreased circulating blood glucose level. So incretin mimetics are those that imitate the incretins, and that would be GLP-1 agonists and DPP-4 enzyme inhibitors. The GLP-1 agonists, those are Byetta or Bydureon, Trulicity, Victoza, Adalimumab, and Ozempic. I am using brand names just because they're easier to say. But among these, we have Byetta, Victoza, and Saxenda, which are daily sub-Q injections, and the others are weekly. So Trulicity, Bydureon, and Ozempic are weekly, which is very convenient. They all come in pens, which is very convenient for patients to use and easy to teach. The main problem with any of these drugs is the cost. So they're definitely a good first go-to right after metformin if the patient can afford it. And this is the reason why we love these drugs. They stimulate insulin secretion when in the presence of glucose elevations. They suppress glucagon secretion, slow gastric emptying, and they stimulate the satiety center so people feel like they're full. And that's what we mean by satiety. And that helps them eat less and helps them lose weight. And it improves insulin sensitivity. It also enhances disposal of glucose. So there's a lot of ways that this works that really is revolutionary for type 2 diabetics. These are some of the precautions. There was concern about acute pancreatitis. There have been some cases of that, so that's a caution. Also, severe GI disease such as colitis and Crohn's disease. Pregnancy is kind of up in the air. Medullary thyroid cancer or family history of it has been known to be a major risk factor for complications. As far as drug interactions, you do need to be concerned about an INR in patients that are on warfarin, and then some drugs will increase the risk of hypoglycemia. Nausea that people have it is actually a very common side effect, especially with the once daily dosing drugs such as Victoza. But it does seem to be related to the amount of glucose load at a particular meal. For the weekly drugs, they tend to be nauseated initially, but that tends to wear off. So that side effect can be overcome if the patient is encouraged. So patient education involves teaching them how to do a sub-Q injection, how to use a pre-filled pen, but that's fairly easy to do. The extended release forms are great. They work better and they're easier to use, obviously. It's a lot easier getting patients to take these kind of injections than trying to get them to take insulin. Cost is the main thing, and that is a sad problem because we could probably save a lot of money in diabetes care if we were able to use these drugs more frequently in our patients. Called the gliptins are Januvia and Onglyza, and they inhibit the DPP4 enzyme, as I said. So this will, of course, also lead to an increase in insulin secretion, as well as suppressing the release of glucagon by the pancreas. So it can also promote mild weight loss in patients that are obese, especially in patients that are diabetic. The DPP4 inhibitors do have some precautions of renal dysfunction. Pregnancy is a bit up in the air, not approved in children. Apparently, in patients that take ACE inhibitors, there's an increase of risk of angioedema, which we do see with the ACE inhibitors, but is a higher risk when given a DPP4 inhibitor. And they also have the thyroid medullary cancer concerns that the GLP-1 agonists have. Next, we have the SGLT2 inhibitors, or the flozins, Invokana, Farxiga, Steglatro. They act on the kidneys. So we're getting away from the incretin hormone system. And these act on the kidneys to promote the excretion of glucose in the urine. So they're novel inhibitors of the renal SGLT2, which blocks, so that causes a blocking of the reabsorption of glucose in the kidneys and promotes excretion of excess glucose in the urine. So that's how it reduces blood glucose. So you do see more glucosuria with this. And that is, we'll get to side effects, but that's the reason we have some side effects here. So they also can reduce blood pressure and can cause some mild weight loss. They can also be effective in patients with heart failure, and so that's one of the indications. Also, chronic kidney disease, where it's more of a compelling indication to use in those patients. So contraindicated in severe renal impairment, less than 30 GFR. You can modify the dose in patients who have between 31 and 60 GFRs, so it's not contraindicated. It can be used. And there are some hypersensitivity reactions, urticaria. Also, there could be an increase in volume of the urine, so that can decrease volume in the blood, and so you can get some hypotension due to volume depletion. But in the face of that, no change in electrolyte balance. Also has caution with ACEs as well as ARBs. The TZDs are Actos and Avandia, and as I said previously, they, as well as metformin, work on the, they target insulin resistance. So they improve the utilization of insulin in the tissues. And so they can also be first line. In a patient that cannot take metformin, and metformin does have GI side effects of diarrhea, which are pretty common, then you could consider TZDs as long as they don't have heart failure or a risk for that. They depend on the presence of insulin for their action, and they improve target cell response to insulin by activating receptor cell proteins in those target cells in the tissues that will then improve insulin action. They also increase utilization of insulin by the liver and muscle cells, and they can reduce liver glucose production. So they are absorbed fairly rapidly after oral dosing. You can see how they're metabolized. There's a lot of interactions because of how they are metabolized, the CYP sites, and you need to monitor liver enzymes, excretion in the urine. So caution in chronic kidney or liver disease, caution in fluid retention, and it can exacerbate or actually precipitate heart failure. There has been some loosening of restrictions, but it's still considered a dangerous drug for those patients. Not approved for children, so anybody younger than 18, you don't use these. And mostly cardiovascular side effects to watch for. And then moving on to sulfonylureas. They used to be first line. I've listed them towards the end of this presentation because they have many side effects and there are so many other drugs. The newer ones, what might be called second generation sulfonylureas, have less hypoglycemia as a side effect than the older ones, which we don't even talk about. The book doesn't even go into those. But the first class of oral drugs that were developed to manage patients with type 2 were the sulfonylureas. Sometimes Amaryl is considered to be a third generation, but often it may be listed as a second generation. These are all second generation, the glucotrol and diabeta. There are a host of what are considered to be first generation sulfonylureas that are no longer used because of the high risk of hypoglycemia. And also they had more frequent dosing. So the second generation drugs, sulfonylureas, are once daily dosing. But they are true oral hypoglycemics and are useful only in patients that have some endogenous insulin secretion. So obviously they have to be type 2 patients that still have some beta cell activity. So due to the risk of hypoglycemia and their limited action on insulin resistance, they're only used in combination therapy. We would never start, these days, a patient on sulfonylurea without first using one of the drugs, especially metformin, to target the insulin resistance, because we can go a long way with that. And you want to maximize the dose of that before you move on. Let's see. So they all the sulfonylureas stimulate insulin release from the beta cells. They have a limited ability to improve uptake of insulin by tissues because they do improve binding of insulin to insulin receptors, but we don't really think of them as being, targeting the insulin resistance. They can have some effect, however. They can also potentiate the effects of antidiuretic hormone, but as I said, hypoglycemia is a major side effect. So once daily dosing, but they also sometimes can work well as twice daily dosing. Start at the lowest dose and titrate every 4 to 7 days according to blood glucose readings. So some of the precautions and contraindications, we talked about hypoglycemia, but older patients are more sensitive to hypoglycemic events. Avoid use in pregnant women and also children. There are cross-sensitivities with sulfonamides or thiazide diuretics. There are some other ADRs other than hypoglycemia, which are listed here. And there are many drug interactions that can decrease or increase the hypoglycemic effects. Some things to consider are that costs, as I mentioned, is not an issue. So this is why we have many people on sulfonylureas when we may, not have them on other oral antidiabetics that would work better. Although we have patients on multiple drug categories, including sulfonylureas, when that's necessary. One thing, the only sulfonylurea that is labeled to be co-administered with insulin is glimepiride, but most of them may be used. Again, this of course would only be for patients who are type 2 diabetics. You would not use it concurrently with patients who are insulin dependent exclusively or type 1 diabetics. Next group of drugs is meglitinides, and Starlix and Prandin are two of those, and they stimulate pancreatic insulin secretion. These are not used that readily, that much. They're not really even listed on the ADA recommendations, and this is why I have them towards the end of this presentation. They increase insulin release from beta cells by closing potassium channels. Again, the main reason we don't see these agents used much are because of side effects. There are some precautions and contraindications, liver impairment. They also are not used in the pediatric population. And you can have hypoglycemia. Really, probably the reason we're not using them is that we have better drugs now. And so they come low in level of priority. There are also lots of drug interactions, antifungals and some antibiotics. And they can also, some drugs can increase the risk of hypoglycemia. Alpha-glucosidase inhibitors are also not as highly recommended. The action is in the intestine. They delay the digestion of carbohydrates, so they can decrease postprandial blood sugars. They're excreted in the kidneys, metabolized by intestinal bacteria. They need to be avoided in severe GI disease, such as irritable bowel, anybody at risk for bowel obstruction or ulceration. ADRs, are probably the main reason these are not used much. Lots of GI side effects, flatulence, diarrhea, abdominal pain. So they're not well tolerated and also need to be used with caution in renal impairment. So the approach to drug therapy, this is kind of just a summary. Again, other courses in your program, the diagnosis and management courses, will go into much more detail about how to initiate insulin, how to treat inpatients, how to treat type 2 diabetics, how to initiate drug therapy for diabetics. So this is just a quick overview. So for type 1 diabetes, of course, they need insulin. That's a given. They don't have any insulin produced in the beta cells of the pancreas, and so they need to have full insulin replacement. And basal and bolus, rapid and short-acting, is most frequently what is used. There are lots of insulin dosing regimens that are in the textbooks. What we see now a lot are continuous pumps in these patients when patients can afford it. They may may have a need for a glucagon kit because of the degree of hypoglycemia that can occur, of course, with use of insulin. So some basic knowledge before dosing insulin: each 15 grams of carbohydrate can serve to raise the blood glucose approximately 50 milligrams per deciliter. So a 1 unit bolus of insulin lowers the glucose approximately 20 to 60 milligrams per deciliter. So you can determine the carbohydrate to insulin ratio and then split basal insulin needs with bolus insulin needs 50-50. Glucagon is an insulin antidote, so it is used for patients with diabetes who experience hypoglycemia or insulin overdose. It stimulates hepatic gluconeogenesis and glycogenolysis, which raises blood glucose levels. So patients should have an understanding of when they need glucagon. And of course, they also need to understand how to treat lower or not as severe hypoglycemia with food intake, but blood glucose concentration can rise within 10 minutes of injection, and after a half an hour, you have maximal concentrations that are attained. There need to be hepatic stores of glycogen, though, in order for glucagon to produce its anti-hypoglycemic effect. It's well absorbed after parenteral administration and metabolized in the liver and kidneys. It can be used in pregnant children or pregnant women and children. But patients that have pheochromocytoma or an insulinoma may be at risk for more complications with glucagon. ADRs are listed here. So, of course, this slide shows the general approach to treatment for type 2 diabetes, and it is based on the 2020 ADA guidelines. First line is always metformin, as I've said several times. And if there are no indicators of high risk for or established ASCVD, CKD, or heart failure, you go next to the DPP4 enzyme inhibitors, the GLP agonists, the SGLT2 inhibitors, and the TZDs. Next, you add one of the above that you had not already tried. So you go through all those agents. Lastly, you can consider sulfonylureas or basal insulin. And there are disease-specific recommendations for ASCVD, CKD, and heart failure, which you can see on the guidelines. But If there's a compelling need to minimize weight gain or lose weight, the GLP-1 receptor agonists or the SGLT2s would be the way to go. And if cost is a major issue, which it often is, the sulfonylureas, TZD, and then finally insulin would be the approach. This slide shows a summary of drug therapy effects that could be considered that are very common. Metformin, as I mentioned, can cause weight loss, and there's a low risk of hypoglycemia. Sulfonylurea, on the other hand, causes weight gain and hypoglycemia. The TZDs need to be especially concerned about risk of heart failure. They do cause weight gain. They cause edema. So they wouldn't be a choice for those patients at risk. The DPP-4s are generally weight neutral, but nausea is a common side effect. So the GLP-1 receptor agonists are actually a better choice if the patient can afford it. They do contribute to weight loss, and there's a low risk of hypoglycemia. The SGLT2 inhibitors I alluded to earlier, they dump a lot of glucose in the urine, which leads to some side effects, including yeast infections, UTIs. There's a potential weight loss benefit, however. And then insulin causes weight gain and hypoglycemia. And that's it for anti-diabetics.